you guys are way over there.
Great. Well, I'm just going to welcome the non-sports fans who made it here today, or non-soccer fans, to our third in the series of ethics grand rounds. And today I'm going to, Dr. David Asiniegas, who is a member of the Institute of Ethics and also the Department of Psychiatry, is going to introduce his friend and colleague, Dr. Kent Kiehl. So, David.
Thank you, Jonathan. It's really a great pleasure to have my friend and colleague, Kent Kiehl, with us today. For those who don't know him, I'll offer just a little bit of background. Dr. Kiehl serves as Executive Science Officer and Director of Mobile Imaging at the Mind Research Network, and as Professor of Psychology, Neurosciences, and Law at the University of New Mexico. He did his undergraduate work in psychology with a biology emphasis at the University of California, Davis, followed by a master's and doctoral degree in psychology and neuroscience at the University of British Columbia. Subsequently served as a assistant research professor in the Department of Psychiatry there, moving thereafter to become the director of the Cognitive Neuroscience Laboratory at the Olin Neuropsychiatric Research Center at the Institute of Living at Hartford Hospital, and faculty in the Department of Psychiatry at Yale. He was there for a number of years before being recruited in 2007 to the Mind Research Network and to the Department of Psychology here at UNM. His laboratories worked collaboratively with a dozen correctional facilities in New Mexico and other states in the US to establish what is now the world's largest database of brain data from incarcerated populations. He and his team use state-of-the-art mobile imaging units, which can be deployed to remote locations, and by virtue of that ability, reach populations for which functional brain imaging and clinical neurophysiologic assessments are otherwise difficult or impossible to obtain. These resources and the relationships he's developed have been instrumental in investigating mental health issues that are particularly prevalent in those who are incarcerated, including psychopathy, antisocial personality disorder, substance abuse, and externalizing disorders, as well as the intersection between these conditions, traumatic brain injury, and the criminal justice system. His works generated over $50 million in NIH funding during the course of his career, 250 publications, to which there have now been more than 31,000 citations, and multiple national and international collaborations. His present portfolio of work includes 6 R01 grants, serving collectively to help us better understand the interactions between brain function, genetics, and environmental factors, and ultimately to improve intervention and prevention strategies in incarcerated populations, as well as better mental health as a whole. His work with incarcerated populations has also included studies in neuroethics, including investigations of the structural and functional neuroanatomy of moral cognition, judgments, and decision-making, which is the focus of his lecture this afternoon. With that, Dr. Kiehl, thank you for being with us, and I'll hand the mic to you.
Well, thank you, Dave. I'm tired after listening to all that. It feels like I should go retire at this point or something. But thank you very much for the kind introduction, and Jonathan for the invitation to speak to everybody today. So I'd like to just jump right in and talk a little bit about our work and the kind of the fun part, I think, if you will, of how psychopathy, how moral decision-making intersects in the criminal justice system, how it raises just a myriad of different interesting ethical issues, from risk, all the way from risk assessment all the way into the ethics of doing even forensic research or research with prisoners. So I'm happy to in this kind of format. I think if you want to type in questions, I think that might be easiest for me to try to help answer them as we go along. But otherwise, we have time at the end for those of you that want to kind of hold on. So when you talk about psychopathy, or you talk about individuals with these traits, let's see if I can get this to advance. People usually picture someone like Anthony Hopkins and his full Hannibal Lecter regalia, or you think about this guy today, Dexter. As if I don't keep up with the current thinking on Dexter, my students find me out of touch with the latest things going on. Or perhaps this guy, and those of you that are in my generation will remember him, Ted Bundy. And people often ask me, so I'll just get it out of the way right now, how did you get into this work? And well, this guy grew up down the street from me, Whereas we never formally met. My father was a writer growing up, and he was talking at the dinner table about this kid that grew up down the street and all the bad things that he'd done. And it's kind of motivated me when I was an undergraduate at Davis to think about what could we do to try to understand individuals like this? How could we come to help try to prevent? And I've been fortunate enough to try to make a career out of it. So that's kind of some of the background of how I got started and how people kind of conceptualize and think about psychopathy. But it's been around for a very long time. I mean, even from the earliest writings, historically, we see that even Moses talked about individuals who had elevated levels of what you would refer to as psychopathic traits, where he described a wayward and defiant son, someone who does not heed father or mother even after being disciplined, so fails to learn from punishment, as a glutton and a drunkard. And so I'd like to talk a little bit more about kind of just the history, kind of the cross-cultural aspects of this condition, how we might develop procedures to assess, these conditions. Can't talk about any history without, speaking a little bit about Aristotle. He had a student who spoke about and wrote a book called The Unscrupulous Man, who described someone as a cheat, a rascal, borrowers who never repay, thieves that are also incorrigible. Dave, I'm not sure if you're muted, but someone's background, I can hear them. So if we can try to get everybody to mute, that would be lovely. These symptoms and these, as they present and how they're different in certain individuals, are also been written about in pretty much all cultures. I've chosen this one. The Nigerian tribes have used this term Aranikan to describe individuals, for example, who always go their own way regardless of others, who are uncooperative, full of malice, and bullheaded. The Inuit have a word called Kunlingata, which is for somebody who knows what they're supposed to do, but they still do not do it. They repeatedly lie, cheat, steal, rape, etc. The Inuit actually have a solution to the problem of psychopathy. They end up putting them on icebergs and pushing them out to sea. If they find individuals with these traits, that's their punishment. Of course, psychiatry has been interested from the very earliest days in understanding individuals with these types of traits. Pinel, who ran the Bicicletra, if I've said that correctly, outside of Paris, France, used this term mania sens delere to indicate and to describe patients who were, unlike his other patients at the insane asylum, had no intellectual problems, no evidence of any forms of psychosis, but they were very cruel, they're very antisocial. They used a wide range of drugs and alcohol. They're very irresponsible, and for our purposes, they were highly immoral. Henry Maudsley actually has one of my favorite quotes, a psychiatrist in England, and he wrote that as there are persons who cannot distinguish certain colors, having what we call color blindness, and others who have no ear for music, cannot distinguish one tune from another. So he argued there were a few who were congenitally deprived of a moral sense. Benjamin Rush, at the founding of our criminal justice system here in the United States, was one of the strongest arguments or proponents for this process that we call moral insanity. And Rush argued that the moral faculty, like in IQ or intelligence, was susceptible to brain damage and should be included in this realm of medicine. That is, we should be talking a lot about the moral faculties and making decisions about right and wrong. In particular, they were arguing that the legal system has to try to come up with a way of understanding these individuals. And that he argued, interestingly, that free will was on a gradient. That is, some people had more or less free will, which is an interesting perspective if we were to digress into free will debates. But I found that to be, pretty consistent with my own clinical experience working with individuals with these traits, is that some of them have a little bit less what you would call free will, I think, than the rest of us. And here, Pritchard, another historical, strong figure, wrote prolifically about this issue of moral insanity, this concept that we should potentially criminally excuse individuals who are unable to make appropriate decisions or have a lifelong problem with making appropriate moral decisions. And like we treat patients with, who are psychotic, who have delusions, hallucinations, et cetera, and can't conform their behavior within a criminal justice framework, we would refer to them as suffering from insanity or having the insanity defense be applicable. He wanted to argue that there should be a construct or a way to include moral insanity. And there are a lot of others that argued this kind of perspective, but ultimately, of course, it didn't take hold, and that we don't have a construct in the criminal justice system today that we refer to as moral insanity. But it is kind of an interesting historical perspective about these things. Now, the construct of psychopathy, or these individuals who have this symptoms and conditions, was really, I think, first ever summarized in a classic academic form in the 1923, where this psychiatrist Ben Cartman pulled together individuals from all over the world to come in and created a symposium where the main goals was to create, what do we all think the symptoms of this condition are? How do we help understand these individuals? How do we differentiate them from other patients? How do we come up with ways of categorizing them, et cetera? And they ended up identifying the following symptoms, and I'll read them quickly here for you. So average IQ or better. Behavior, though, is very atypical for individuals of a normal intellect. They lie a lot. My favorite word for this is mendacity. That is, they don't reach the level of confabulation, but they do have very commonly make up stories, even stories that can be easily checked, and they're often just caught flat in the middle of a lie, and it doesn't seem to faze them or cause any problems. And of course, they will lie for monetary gain and other types of things, but their hype is just completely untruthful in all aspects of their life. They fail to appreciate how their behavior impacts others. I mean, this is often true where you'll see letters in people's guys' files where their parents have indicated that they just cannot have this individual come back into life again. They do not want to support their parole options, or to be somebody that they can come stay with again, because they have just caused them 20 or 30 years of grief. And it's often striking when you'll ask or be interviewing somebody who has high levels of these traits. What do you think about the letter in your file that your dad wrote? There's one, oh, he'll get over it. He'll be fine. I mean, he says it all the time. And then when you go and see what's happened at the home and the problems that have occurred, it's just pretty striking that they really, really fail to appreciate how their behavior impacts other people. This behavioral pattern is very resistant to change. In fact, for a long time in psychiatry, it was often considered immutable. That is, you can't change individuals who are on this course or on this trajectory. And so therefore, we often just kind of ignore them and they just go away, and they're not been proper studies in treatment designs. In fact, to my knowledge, there's only one study that has ever been done that was a randomized, treatment control study to try to mitigate these symptoms. So it's extremely resistant to change, and that has led to a long history of people not trying. Punishment, that is, the threat of punishment or other aspects of punishment, are ineffective. I mean, David Licken and others in the 40s, 50s, 60s created kind of a very large literature showing that these individuals are just insensitive to punishment. Reward, on the other hand, is completely different. They may be hyper repetitive for reward-related processes, but the threats of punishments, other types of issues, simply just do not come to pass, don't have any effect on them. No psychotic symptoms, and this is, again, to differentiate these individuals from other patients that the psychiatrists were often seeing, is that there was no evidence of any psychosis. And in my own experience, we published a number of papers kind of confirming this kind of same result. It's extremely rare to find a patient with schizophrenia who also meets criterion, for this condition. It's very strange when you see one. I think I've 1 out of 200 forensic psychiatric patients that I've interviewed has ever just met the criterion for psychopathy. And it was strange. This person was clearly antisocial before the onset of any symptoms, had a lot of different problems and other issues, but then the delusions, hallucinations of grandeur and other things that permeated this individual's life crept into having them scoring a little bit higher than you might expect. And so they then did kind of meet criterion, but it's extremely rare for someone to have any kind of a comorbidity with psychosis. A profound failure in all emotional domains, that is, they have basically very low emotional IQ. This pervades into things like lack of empathy, love. Love is often equated to be like a physical emotion. They equate it to sex. You ask them, who have you ever been in love with? And they'll be like, oh, there's 2 girls once. They'll just kind of express, no ability to kind of understand abstract concepts, things like, love or feelings and other types of things are really lost on them. No sense of guilt. Very early in life, this is very much a developmental condition. There's been a lot of research in the last 20 years on assessing and measuring these traits earlier and earlier to try to help get an understanding of how we can try to, treat or manage kids who might be on a trajectory towards developing this condition as an adult. It never typically magically appears. It's not like psychotic symptoms or anything like that. So very long developmental course. Delinquency often early, often before the age of 12, in the absence of any types of peer pressure or gang involvement or anything like that. It's common. Promiscuous sexual behavior kind of goes without saying, really. And then alcohol and substance abuse in excess, but it's different. And what I found interesting about this is that's been my own experience, is that individuals with these traits tend to just use and abuse drugs for fun. They don't seem to actually end up becoming kind of dependent. They tend to migrate from any drug that's available rather than sticking to any certain class or other process. And I think that just makes it a challenge to try to come up with then, or to generalize our treatment programs from certain individuals with clear addiction to individuals with these types of processes. I think individual differences are very important when you're considering treatment for substance or alcohol abuse. But these were the first 13 symptoms that were established. This was buried in an abstract, journal that I dug up in the while I was writing a historical, treatise on psychopathy, and I found it to be really, fascinating. And then subsequent to this, we had, just to kind of summarize the points here, that these guys have been around for a very long time. People have written about them, basically forever, and they really do pervade literature. They pervade movies. They pervade all different areas, and sometimes they're good characterizations, sometimes they're not. It doesn't appear that psychopathy discriminates. We find that the base rates are very similar across all different types of ethnicities or cultures or backgrounds. We do find a huge gender effect. There's about tenfold as many men who meet criterion for these symptoms as we do women. And we do see often, and the estimates from our lab and others are somewhere around 80% of individuals who meet clinical criterion for the condition also end up in the criminal justice system. If not for long periods of time, at least they kind of go back and forth inside and out of the criminal justice system. And we really consider the condition to have at least these two domains. One of these interpersonal and affective traits, the lack of empathy, guilt, remorse, etc., which is really kind of unique to this condition. And we also have this kind of profound poor decision-making and ability to appreciate or have insights and impulsivity and poor planning that we refer to as the impulsive, antisocial traits, which are often observed in some other conditions as well. Can't really have a talk summarizing kind of the background or history without referring to Hervey Kleckley. He wrote 5 editions of The Mask of Sanity. Hervey was a clinician who worked prolifically and wrote prolifically but up and down the East Coast. He was primarily stationed in Georgia, and he would travel all around the East Coast working with and studying and treating patients both in hospitals as well as for private families. And he, essentially came up with what we consider to be kind of one of the first groundbreaking, studies and treatises on psychopathy. His book, The Mask of Sanity. And Kleckley came up with these 16 characteristics, of which the majority of them overlap extensively, here highlighted in blue, with the early criterion some 20 years earlier that the Ben Cartman's group came up with. And Kleckley added a few other, traits that he considered to be important. One is a couple of which are things like their antisocial behavior is not necessarily motivated by, the need to survive or the need to, support their habits or other things. It was basically often these individuals came from average or above average, wealth and income, and they did these antisocial traits and had these antisocial behaviors and problems, even in the presence of these things. So there's kind of unclear what would motivate them to act like this. And Kleckley added a few other things, and also noticed that we generally don't see individuals with these traits attempting or trying to commit any suicidal behavior. So on the other hand, we have found that high risk populations like this do have about a tenfold increase of early mortality. In some juvenile longitudinal work that we've done, we see that the kids that basically, even from average to scores in this, are extremely high risk for early death compared to peers in the community. And subsequent to Kleckley and his kind of descriptions, really it was the work of Bob Hare who decided to create a scale, to create a test, to create a way of trying to measure these traits reliably, accurately, even in the presence of an adversarial situation like a risk assessment. And he developed what's called the hair psychopathy checklist, which was revised a few years later. And this has been out now since, the early 90s. And one of the strengths of the psychopathy checklist is that it hasn't changed in, almost 30 years, which has allowed just an enormous literature to be built, worldwide. People who like the instrument, people who don't like the instrument, people who want to study the psychometrics, want to study outcomes. It has been used just all over the world. In fact, many countries mandate its use for risk assessment and other processes and procedures, but these are the traits. Just a highlight, most of you are probably familiar with the issue of personality disorders, but here we're trying to make sure that we're finding these traits in all aspects of their life and for the vast majority of their life. And so what we're seeing is evidence of these types of traits at home, at work, at school, with family, with friends, pervades all aspects of their life and for the majority of their life. So we don't tend to see that this is a blip on the radar of somebody who makes a difficult or harsh business decision to lay off people, for example. That might not be a great boss to have, but it's not necessarily evidence for high scores on these traits. And so this is something I like to kind of highlight, is that we have a strong important need to assess these traits in all domains of life, as well as in all aspects of someone's life. Okay. And often people will ask, like, what do I really mean, by things like lack of empathy, guilt, and remorse? And in a second, I'm going to try to give you an example. But the traits here, if you look at the North American forensic, populations, they're normally distributed. You have, the average male listening to this lecture is going to score no more than 4 or 5, on the scale, hopefully. The average inmate will score about 20 out of 40. Each of those items was scored a 0, 1, or 2. So the 0 indicates that the item and the content doesn't apply to you at all. A 1 indicates that it applies to you in many domains or for a significant number of domains. And then a 2 means that it, you just fit perfect. This criterion, this item, fits with all aspects of your life. And so the scores can range from 0 to 40. And originally for statistical purposes, and today, 30 and above is essentially what people will use as a categorical, jump to say that this individual who's different, who's in this high group. Our own experience has been, more in the 34 and above, really as an individual that then, all the hands in the room will go up when you ask if this individual meets your kind of classic definitions that you would expect and meets all of the symptoms. And so there definitely is some error, some rounding error, if you will. Then you want to really focus on those that are clinically, different. It's going to be the score of those that are like 34 and above, which is fortunately just a minority of about 10 to 12% of inmates, and higher than that if you get into the supermax. In fact, New Mexico, often we find that the rates of these traits really scale with security levels. So individuals who have high levels of these traits tend to get themselves in trouble, even institutionally, and they end up matriculating up towards the highest security levels. And we do see this in most other states. In fact, a lot of, even the FBI has studied and examined and finds that, upwards of 50% of law enforcement, of men or in law enforcement officers who died in the line of duty were killed by somebody who scored, high on these traits. And again, just kind of emphasizing that they really have very poor decision making, and they very much have no, well, if you will, their moral decision making is truly impaired. And so, you might be familiar with the construct of antisocial personality disorder. We could digress into a very long discussion about the differences between psychopathy and antisocial personality disorder. But in essence, antisocial personality disorder wasn't really designed to work with forensic populations. It was kind of a way of having the average clinician in the community identify that might have an individual with high reliability, because the symptoms are very easy to assess and kind of biased towards the impulsivity symptoms rather than the lack of empathy, guilt, and remorse, the more challenging, more difficult to assess symptoms. Whereas the hair scales were really designed to assess and work with forensic populations. And if anything, that's one of their limitations, is that they're primarily focused on trying to help differentiate within that sample, not within other community kind of based samples. So there are variants of the instruments that have been developed to try to help that. And so we see this kind of asymmetric relationship, that is upwards of 80 to 85% of incarcerated individuals will meet criterion for antisocial personality disorder. We're only a minority, upwards of 20%, sometimes higher to 30% as you get to higher security classification, will meet criterion for psychopathy. And so we have this very asymmetric relationship. And I just highlight that to try to illustrate that the terms are sometimes used synonymously, but really it just comes down to being careful that if you're going to read the literature on psychopathy that use the Harris psychopathy checklist, then you wouldn't want to apply that to an individual who has just antisocial personality disorder, because they're really not the same. And so it's really an unfair comparison. So we always emphasize, oops, see I typo on that, it's supposed to be predicts behavior. We're supposed to just stick to, if you're going to do a risk assessment on a client, you would want to use the Harris psychopathy checklist if you're going to try to relate the literature on the Harris psychopathy checklist to your clients. All right, so I one of my fun things that I came up with and trying to help people understand or kind of think about what does it mean to have a lack of empathy, guilt, or remorse. I often, what is it like talking to individuals with these traits? How do they actually, present, et cetera? And so this is an example that I've come up with. So what I want you guys all to do is that this example is designed to help you kind of feel what it feels like, or what they tell me, it feels like to have no empathy, guilt, and remorse. So here's the example. So I need you guys to solve this. Right, so it's hard to do by Zoom, but my guess is that most of you have never seen this field equation for Einstein's theory of relativity. And so you have to look at it like it's a foreign language. And that's the way that individuals who have high levels of these traits talk about empathy or talk about guilt, is that it just doesn't come to pass. There's just an absence of it. They just don't feel, they don't have that intuitive, experience and feeling. And so we hopefully that gives you kind of just this perspective. And it's interesting because most of us just take this for granted, how you feel about your kids or your parents or your wife or your siblings, that's, you just have this, you have this intuitive affect for them. But individuals with these traits, they simply lack that. And it's really clinically just fascinating. You tend to see the assessment of psychopathy used throughout the criminal justice system. By far and away, though, it's used in risk assessments, and particularly it's used in like civil commitment. So if you have somebody that has under a Megan's Law or similar, going to be sentenced to commitment following completion of their prison term and determined to be a dangerous individual, then psychopathy assessments are traditionally part of that. We've also seen them used routinely in like juvenile transfers, so trying to raise someone to adult court who's saying they're super high risk, they've already got these traits. We can discuss those types of issues. They're not without any controversy for certain. You do see them used in capital sentencing. And we've seen them both sides, for defense and for prosecution, have tried to use the construct. But by far and away, it's used mostly in risk assessments. And so if you're performing some sort of a sexual-based or assessment of sexual risk, and like these Megan's Laws, that's where you tend to see being used most commonly. And then it's smattered throughout the other types of programs. And in many countries, the assessment is required as part of risk assessments. And in our work here, we generally find that the psychopathy checklist is right behind age, the second most powerful predictor of future poor outcomes. So continuing to reoffend. And let's talk about some of that data now. So why do we care about this? Why do we care about these traits? Why do we measure them? Why would we spend 2 to 3 hours per client, interviewing and assessing for these traits and trying to understand them? Yes. Someone. So for this is called a survival curve, and so this is a curve where essentially this is Canadian data. They have a nationwide offender tracking system, and so it allows researchers to catalog individuals by high, medium, or low psychopathy, for example, and then to follow them up. So this is a prospective study that was done years ago, one of the first that found that individuals who have high levels of these traits are more likely to reoffend and also have a higher rate of reoffending. And so some 80% of subjects in this category here had reoffended in a 3-year follow-up, versus, if you're on the parole board and you have clients that are low on these traits, have very low levels, well, they're just a 1 in 4 or 5 risk for reoffending within 3 years. And so that's a pretty big difference. And so the traits have a lot of predictive power. But where they've really gotten the biggest value has been in predicting future violent outcomes. So these were individuals who were all convicted of a violent offense, and then they were released at some point, followed up for upwards of 25 years in this study. And what they were able to show is that those that scored high on these traits, again, almost a doubling of risk for violent reoffending, in the future. And so 7, 8, 9 years out, upwards of 80% of the sample, they're reconvicted for a new violent crime. And violent crimes are the ones that we're generally most interested in preventing. They're the most costly, they're the most damaging, et cetera. Other, people have also looked at certain treatment effects. So basically what you're seeing here is, that individuals that have high levels of these traits are more likely to reoffend if left untreated than individuals who don't have these traits. That's kind of the same graph, just in a survival curve now, just in a bar graph. And in this study, they found that certain forms of treatment, this is a group-based kind of treatment, is definitely something that was a little different. It was done in like the late 60s and 70s. And it wouldn't be a treatment that we probably implement today, but they did find that they had a treatment effect. That is, the men that completed the treatment program were less likely to reoffend than them if they scored low on psychopathy. But then when they looked at those scored high, they were like, uh-oh, this is a problem. So we potentially have an iatrogenetic effect. We're actually making them more likely to reoffend. And they would go interview these guys and talk to them and what happened. And I didn't really understand, they would say, about all these, other individuals would cause them distress and other things. And so I didn't know that, if I was to, manipulate their brother or sister or wife, that they would get them to do what I wanted them to do. And they basically use these skills to kind of learn how to be more or worse. And so there's this controversial study. It's not necessarily wasn't a fully randomized design or anything like that. It was simply kind of retrospectively done. But nevertheless, it kind of highlights that these individual differences may need a different approach than is what typically done in terms of group therapy, and that individuals with these traits often have very different risk factors. Work by my colleague Gina Vincent. She's actually been was a Kiehl awardee in my group, and she published this work showing that youth who basically maximum security incarcerated youth have a rough doubling of risk if they score high on the adolescent version of these traits compared to the other incarcerated youth who score lower. And again, this is for violent reoffending. And so, to my knowledge, psychopathy checklist is the single best instrument for predicting future violent risk that we know of. The relationship between psychopathy and future violence is like 0.37, 0.4. For example, by comparison, the relationship between cardiac or chest pain and a cardiac arrest is like 0.15. There's lots of reasons people get chest pain. Only a few of them relate to having a cardiac arrest. So there's, in terms of the size of the effect and the prediction effect, it's really quite striking. And whether we're studying men or women or youth in New Mexico, Wisconsin, where we work, or Texas now, we continually see that this instrument has just very powerful predictive, utility. And it just continues to impress. And so it's very interesting when you can kind of help predict where someone's going to be with a very high degree of accuracy and where they're going to end up in the next 5 to 10 years. All right, so that's kind of the clinical background. I just want to kind of summarize this issue and that's associated with this construct we call psychopathy, how we measure it, how we assess it. It is done, but through this expert rater process. That is, trained raters go in and interview an individual in all domains of their life and talk to them for several hours, and then review all their collateral file information, try to make sure they haven't been lied to, or the person hasn't made up stuff, or if they have, then you use that to help score those items. And then you have an expert double rate these items on that instrument, and then it's that score that helps provide the predictive power in all these analysis. And we often have most of our, we record everything, we usually have everything double rated, or at least a large proportion of them rated by somebody else. And then the two assessors will, compute kappas to see if we have good agreement or not, but then also kind of have individuals come to some sort of a group-based rating to try to help make sure we're getting, all of the available information together to try to get the right score, because it has such a powerful predictive, value. So I'll turn now, and there's any questions, I'm happy to answer them about assessments or background or predictive utility or treatment outcomes and other types of things. But basically, individuals who have high levels of these traits are extremely costly. I did an economic analysis with a judge up in Colorado a few years ago, and we wrote a paper on it. And some parts of $400 billion a year is the expected cost for individuals with these traits, and that's a staggering amount of money. When you consider actually the societal cost of crime, at least in the United States, is upwards of $2.3 trillion a year. and these individuals make up a significant minority of the criminal justice population in the United States. And they're also commonly, commit kind of the more costly types of crimes, and especially those that relate to homicide, the most expensive type of crime, societally speaking. We do see that this is probably one of the most expensive societal costs, and from a societal cost perspective, conditions it's out there. All right. So talk now some about the neuroscience, about decision making, about kind of moral decision making, and these types of processes. And so this map that you see here, this was a colleague of mine put this up in a talk in Grand Rounds when I was at Yale, and I looked at it and I just found it kind of fascinating. I hadn't seen this Brodmann map before. This one colored this way, and essentially highlighting the areas in green are the regions that I'd like to just chat about a little bit more detail, which is that the temporal pole, the entorhinal cortex, the anterior cingulate, orbitofrontal cortex. These were all regions that, years ago, we had varying studies that found effects there, whether it was with functional MRI or with some sort of structural analysis, et cetera. We would see that it's the areas in green that basically seem to be related to psychopathic traits most commonly. And I didn't really have any kind of a hypothesis or a kind of a framework for thinking about this from a developmental, from a neuroscientific perspective. And so this circuit that Brodmann referred to as this paralimbic circuitry appeared to be what is different in individuals with these traits. And so I wrote a paper years ago now that basically argued that these are the areas of the brain, the green areas, that are here to be most disrupted in individuals that have high levels of these traits. And then we sought out to kind of test that hypothesis when I moved here, some of the techniques that we'll talk about. But one of the areas that I reviewed, which will probably be familiar to most of you, was what happens to individuals who might have some sort of impairment or suffer some sort of brain injury to these areas. Do they develop any kind of symptoms that might be consistent with, psychopathic-like symptoms? And of course, what most of you will remember this guy. So this picture I know just surfaced not long ago is Phineas Gage. And Gage, of course, I've been to the location in Vermont where the accident occurred. He had this rod that was shot up through in an accident through the side of his cheek and out the top of his head. And it's pretty amazing. One, that he recovered from this or lived through this event. Two, that somebody actually wrote about it and documented the changes that occurred. And of course, we now know that damage to these areas here in orbitofrontal cortex lead to this acquired sociopathic or psychopathic syndrome that we see individuals who have just change, quite a bit. And it's generalized, not just orbitofrontal cortex, but even bilateral cingulate lesions, anterior cingulate lesions will lead to almost the same, condition. I have a colleague, Diane Swick, who's in at UC Davis, and she often would have an annual lunch at the meetings we would attend together, or she would want to just talk about this patient that she's been managing that has rare bilateral cingulate lesions, and how he meets kind of all of the criterion for, she thinks psychopathy, and we just talk about the behaviors and the symptoms, the problems, and that this individual has gone through. And again, it's extremely rare. And there've been a few other papers on summarizing kind of these, patients, but it does need to be a bilateral. Unilateral damage doesn't appear to lead to these kind of behavioral changes that are associated with these conditions or symptoms. And of course, you don't see like full-blown changes that we might expect, but they are measurable and noticeable, but we don't necessarily see all of the symptoms of psychopathy, in individuals who just have some of these traits. But for those of you who worked with, medial temporal lobe epilepsy or work with individuals with medial temporal lobe issues, you generally can see some flattening, some lack of affect. You see some of the same symptoms. Sometimes their sexual behavior is inappropriate. You see a variety of those things. There's been more than a dozen case studies now published about orbitofrontal lesions or tumors causing inappropriate behaviors, from sexually based inappropriate behavior to, downright, aggressive and very poor outcomes. And so then my colleague, Mike Koenig, who for years was in Iowa with Trinell and Damasio, et cetera, he published a series of studies looking at patients who had orbitofrontal, damage. And here we have patient EVR, and EVR was basically an accountant. Well, we've all had good or bad experiences with various accountants, but was an accountant, married, father, respected, good intelligence. And after the lesion, squirreled away his money, lost it, got divorced, remarried, an individual, and that a prostitute, was then divorced again, estranged from everybody, and people would say that he has no guilt or empathy. Surprising to me, he actually showed up for research, but nevertheless, very poorly modulated anger, but was smart, and so didn't appear to have any intellectual deficits, and so had all these behaviors. And of course, Damazu and others have written extensively about these patients with damage to this area and how different they become, and how potentially, psychopathic or a good model for psychopathy. And in relevance to this, lecture, many of you may remember these trolley car dilemmas. In this example, philosophers love these types of things. They're a little bit more difficult to kind of do work experimentally with them, but here goes. So you have this trolley car that's coming down the tracks, and it's going to run down these 5 men here on, if you don't do anything, but you're standing there and you realize that if you push this little switch and it'll go down the other track and it will only kill one. So would you push the switch? And I'm not going to make everybody raise their hands or do this, live experiment, but 80% of undergraduates will say that 80 to 90% that they would push the switch to save 4. A very straightforward kind of an assessment. And then it changes. And now the example is, well, now you're standing over a footbridge and there's a very large individual. And if you push that individual off the bridge, they will die, but it will stop the trolley. So the same calculation, you kill 1 instead of 5, and so you save a net of 4. And would you push them? Well, typical undergraduate population will be like, there's something wrong with that. They often say, no, I won't push them, and it switches. And now only 10 or 15% will say they would push the person, versus and 80% say they would not push the person off the bridge to try to save the others. And so what's different about these two scenarios, and again, moral philosophers and others, and Josh Green and a variety of colleagues might have studied this in great detail, and basically people argue that there's this personal effect, that there's this proximal effect that you've got here, and we refer to this as a you have a non-utilitarian kind of decision if you consider affect or emotion. And many people have published papers showing that these types of scenarios engage this limbic circuitry, especially this amygdala, when you are thinking about having to push somebody off the bridge versus just push a switch. It engages this affective circuitry. And so the question then becomes, well, do individuals with orbitofrontal damage or do individuals with high levels of psychopathic traits, do they show the same processes? Do they have the same types of resistance? What's going to be their kind of decision making? And what they found in this early work was that patients with ventromedial prefrontal lesions, that is these orbitofrontal lesions, they are more likely to respond in the utilitarian. That is, they would argue that the affective input is kind of lessened, and so they end up having an easier time making this decision. Back years ago when Mike wrote up these results, it was one of the more unique patient groups that this behavioral effect was observed, that they basically had less concern or resistance doing that. You can actually get the same results here if you put people through like a logic and reasoning or like graduate school in philosophy. Apparently most philosophical or philosophy PhD students at Duke anyway, where my colleagues study this, they start and they fill it out with a very utilitarian, and then by the time they finish their PhD in philosophy, they're very utilitarian, and they ended up switching. So I don't know if it's necessarily an orbitofrontal lesion might be induced by Duke's philosophy program, but they end up seeing that individuals make more utilitarian responses as they study these types of scenarios as they go through education. So it's not that it's necessary to have a orbitofrontal lesion, but it is striking that they find these types of behavioral effects. And then Mike also had a sample that we worked with of individuals who scored high levels of traits. These are incarcerated men here. And if the so-called primary, that's an individual who scores high in psychopathies and also has very low anxiety scores. It was that group that basically showed less affective responsiveness to these traits and so, or this condition, and had a more utilitarian, versus those that were high in psychopathy and also had a high anxiety or higher anxiety, if you will, than relative to the primary group. They basically had a very similar type of behavioral responding. And so the argument here then is that these orbitofrontal patients, these individuals have less affect that might be being involved, and individual psychopathy, similarly, they make these utilitarian responses more commonly. We've done a variety of these different decision-making types of paradigms with them over the years, and behaviorally, what you generally find is that individuals with high levels of these traits, they struggle if you give them a moral decision making in which you need to require, where you require that they're fast and accurate for making a moral decision. They tend to be slower, they tend to make more errors, but cognitively, they are always typically capable of telling you what you want to hear. And this follows with that some of the clinical insights is that they know the words, but they don't know the music. That is, they can articulate what you're interested in hearing, and they can tell you what you want to hear, and they can say they're going to be better or good or not do things, but then it just is lost on them. They don't actually follow through with that. They don't seem to have any continuity of thought, or they don't seem to be able to plan and carry through with those types of processes. And so again, behaviorally, in individuals with these traits, they don't seem to have any cognitive impairments. They pass all the neuropsych tests. They don't seem to have any intellectual impairments, although they are lower on emotional intelligence than as you might expect compared to other inmates. But it's sometimes a struggle to get them to find a behavioral effect in which you see marked evidence. Again, there's a few tasks that kind of lead to behavioral effects, but it's generally traditional neuropsychological assessment doesn't penetrate the condition that we call psychopathy. All right, so if we wanted to now study individuals like Hannibal, well, how would we do that? If we wanted to use modern kind of neuroscience techniques, one of them which we'll talk a lot about is this one. This is called voxel-based morphometry. For those of you that aren't familiar with image analysis, we're going to collect a high resolution T1 weighted image from an MRI on everybody. We're going to then standardize and put that brain in standard space. I think you can see this mouse here. So we're going to put everyone's brain in the same space, so-called spatial normalization. We're going to segment out your gray matter or the thinking areas of your brain. We're going to then preserve concentrations and size, and then do a little bit of smoothing because these processes aren't perfect and everyone's brain's a little bit different. And then we have a picture, kind of your kind of thinking areas of the brain. And we're going to study the muscle mass in here and study the density and study this and try to understand how things are different. And, this is a very powerful and commonly used technique. We find, unfortunately, for those of us that are aging more quickly than we would like, what we do find is that, this technique is highly sensitive to the aging process. So all the areas that I plotted in blue there for you are showing this negative correlation. That is, as you get older, just like you lose muscle mass in in your legs and arms, you also lose muscle mass in your brain. That is, you find that there's less density in all of the different areas. In fact, very widespread. It's a very common and interesting area of research right now is studying the aging brain and studying how this technique can allow us to predict things like cognitive decline or MCI or a variety of other processes. Our group has contributed to this kind of work as well. But you can also see regions of the brain that kind of show an increase. So for example, as you age, we tend to see some areas of the brain get thicker, and some of these areas are in the cerebellum here, but also even hippocampal structures are shown measurably changing as you age, which is obviously storing, we think, density or memories. So we tend to see that this technique is highly sensitive to these types of effects. You can also measure IQ, and you can correlate IQ with this density measure, and you can find that all of the regions here are related to verbal IQ. You're getting a ton of stuff going on in the cerebellum as people try to articulate and pronounce words, for example, on this test. And so there's just a lot of value in doing this type of an assessment. But if we return to Hannibal, we can try to, well, how would we do this? How do we get the MRI to Hannibal? Well, we could transport him. You remember what happened in that case that didn't go so well. And so, when I first moved from Canada out of graduate school to Yale, we asked, could we bring out inmates from maximum security to study them and do research, and the flat no from them, pretty much any of the areas in the States and like a 100-mile radius, they just weren't interested in doing any research where that might involve transporting inmates from the facility to the university hospital to get scans. And so after a while, we kind of realized that maybe one of the only solutions, or at least a solution, was to do this. So I live in New Mexico and I have a trailer like many people do, but this is a very nice trailer and it has an MRI in the back of it. In fact, we now have 2 of them. And with this unit, we have been able to do all sorts of research on forensic populations or even hard to risk populations. With Gary Rosenberg, we actually take the system out to some of the pueblos and work with patients or clients out there. We have done to study other types of issues like TBI and aging and other processes. We've had proposals to take it to various military bases to study men before and after deployment. We've done We've done studies looking at like take to an elementary school and study a lot of kids there versus trying to get them to come to the institutions. So basically it's designed to go where the patient population is located and collect high volume data. We traditionally have it roam about a month a year to various facilities that we work at. So you go in and do your assessments and they collect the data on everybody and then bring the scanner in and scan as many people as you can in a month and then move on to the next site and so on and so forth. So it's proven to be a very valuable, very robust system, to be honest. And we've definitely beaten on it quite a bit. It's probably it's been to more than 20 different prisons in the years that we've had this thing. And we've collected a lot of data, and a lot of people in my lab have spent a lot of time in maximum security facilities working with individuals. And so, over 3,000, adult male incarcerated subjects, upwards of close to 1,000 now women that we've been working with. And again, we do a lot of treatment studies. We study how the brain changes with, for example, mindfulness treatment. We have a lot of studies looking at, treatment for substance use, treatment for impulsivity. We do a variety of different work. We followed up on several different youth samples, and we've even worked with some of the highest risk offenders, those that have been civilly committed in different states. And then, of course, we've been interested in working with forensic psychiatric populations. That is, how do you help understand risk? How do you help understand, how to manage and treat, individuals who have both, an Axis 1 psychotic condition typically, and then also have some sort of poor intersection with the criminal justice system. So we have worked in a variety of forensic systems all the way up to Canada. We went to Penetanguishene, well, they now call it Waypoint, and scanned 100 patients up there as part of a collaborative work. So, basically the lab has been, working on a variety of, essentially if individuals or populations that get in trouble, we're interested in understanding how they get that way, how to treat them, and how to help, manage them and improve things. I'm happy to talk about these things in more detail if people have questions. So the first study, of course, we wanted to understand was, well, what about the gray matter effects? What do we see in individual psychopathy? So we had years ago, we had a student, she came in, she was a postdoc, and we had her work on, looking at, how the brains of individuals, relate in different gray matter. I'm realizing I'm talking a little long, so I think I'm going to kind of go to the summary slide here. And over a series of studies, what I'm plotting for you here is gray matter differences. Let's see, Kent, we're at 12:55, right? So let me try to just give you a quick summary of some of the neuroscience, and then I'll take questions. The blue areas here, which you can see are highly similar between adult males, adolescent boys, adolescent girls, all of whom were incarcerated, all of whom have very high levels. Is plotting negative correlation. So basically the higher the score they have in these areas on psychopathy, the lower gray matter. And one way to think about it is that it's about 5 to 10%. So it's right around 5 to 7% less gray matter in these areas of the brain, the higher they score on psychopathic traits. And of course, these are the classic areas that many of us associate with these traits through brain damage or other, work, which is this orbital frontal cortex, amygdala, parts of the cingulate gyrus, and temporal pole are some of the main regions that show up as being different. I've realized I've run late, and so I do have other slides. I do have other things we could talk about if there are questions. And what I'd like to do then, but I'm just going to go ahead and thank everybody that's worked in the lab. I always feel like I need to acknowledge that I send a lot of people to prison, and we have a lot of people that do hard work commuting back and forth to various sites. I have written about all of this. If those of you that are interested in an Audible book on these types of assessments and traits, I'd be happy to talk about that. And so I'm also happy to, I'd like to just stop and just take questions because I've run a little bit late here. So thank you very much for your attention, and I'm happy to answer any questions anybody might have.
Mona, could we collapse the slides and see if
Yeah,
we can
of
get
course.
people to, yeah.
Right, so first question. So adverse childhood experiences, absolutely. So the two main points I'd take home from there is that there's absolutely a very strong relationship between the impulsive antisocial traits and early adverse experiences. So we and others have published many studies showing that it appears to be very predictive of the expression of those traits, high levels of early childhood adversity and particularly trauma-related experiences. However, the interpersonal and affective traits in some of the samples that we've worked with don't appear to be predicted by trauma-related experiences. So it doesn't appear that trauma relates to the expression of lack of empathy, guilt, and remorse in an expert rater assessment. Now, if you use self-report assessments or parent-teacher assessments, that tends to be a slightly different story. If you work with non-clinical samples or people who might not have full clinical levels of these traits, we just don't know. So we're still, and it's still an active area of research, but the conclusion I think from it is that certainly the poor decision-making, impulsivity, acting out, there's lots of evidence that those traits appear to be related to poor experiences, et cetera. Right, so suicidal stuff. Right, this is again, suicidal behavior in this context that this Kiehl and the others who wrote about it, that was really differentiating patients in a kind of, in an insane asylum. So if the individuals, there's very high rates of suicide amongst other patient populations, as you all know, versus the individuals with these traits appear to have much less of a risk compared to those patients. And threats are different. So individuals with high levels of psychopathic traits are very likely to use threats and coercion and other types of things and hurting others or hurting even themselves. And we tend to see that more commonly in women than in men. But actually following through and committing suicide is extremely rare in individuals with these traits. And so that's been a general kind of consensus in the field. And so that's what has generally been seen. The trolley problem. Right, so I got really, a good question about the trolley problem. So in fact, when Josh Green, who's at Harvard, asked me the trolley car dilemma years ago when I was in Connecticut, I actually said, well, I think the best answer is that you should jump and kill yourself, save the guy in the footbridge and everything else. And he said that you're not supposed to answer like that. And I said, well, isn't that probably the most altruistic, example? But individual psychopathy would never come up with that answer. I like to think, but let me see, sorry, back to the question. I think the individual psychopathy in this context of these trolley cars are trying to answer in a socially desirable fashion. So they are trying to come up with what you think they want to do. Honestly, I think what's interesting is when you scan their brains, and I was going to show you some other data, the limbic circuitry that we normally see engaged in individuals who are low on these traits or in healthy controls, the orbitofrontal amygdala circuits that pop up when you look at processing moral stimuli, that individuals psychopathy don't see that, whether that's an implicit deficit or as an explicit, top-down deficit. That engagement doesn't happen. And so yes, they probably are more likely to say, I don't really care about this question. But when I'm asking them, and paying them a couple dollars an hour in the prison to answer it, well, then they're like, I know you want me to say this, but I'm not really worried about this question. So Gary, the question about CT or postmortem, no, there is no studies at all on individuals with high levels of psychopathic traits in postmortem tissue. I used to play squash with one of the pathologists at UNM, and we would talk about how it would be lovely to collect a bank because all violent deaths end up in UNM's pathology department, and to try to create a bank. And maybe, this was 15 years ago, maybe in hindsight, if we should have tried to do that, maybe we would have enough individuals, collected at this point, but unfortunately, there's no such bank. It would be lovely to do. Dave, given the nature of these neurodevelopment differences, what interventions, if anything, might normalize those areas? Great question. And I traditionally try to end with this. So there is a program in Wisconsin, takes almost a year in high risk, kids. It's a behavioral positive contingency management program. So they use rewards to try to reinforce positive outcomes, even from talking to your therapist to, all the way up to, participating in these smaller groups, and then MST, multi-systemic family therapy, all sorts of processes. But they use a contingency management or positive reinforcement to try to get the kids to engage who have high levels of these traits. And what they have found is if they get these kids through a kind of almost a year of this type of treatment program, they do see positive behavioral outcomes. That is, they're about 50% less likely to commit new violent crimes compared to peers that don't get this type of treatment. And that for us was significant progress. And I've written about this in my book, I've written about this in other papers, and they've published the actual data on this as well. But it's it is true that there appears to be some forms of treatment that do help to at least reduce poor outcomes in terms of additional, violent outcomes. And it is this type of positive reinforcement community management based work that appears to work best. Neurally, we have been scanning them. We've been trying to figure out how their brains are changing with treatment. Obviously, COVID interrupted some of that work. And so we have a lot more to do before I can speak definitively about that. Okay. Do we have any other questions? I mean, we didn't really talk too much about the ethical kind of implications. I do get a lot of those types of questions just generally about ethics of risk assessment, ethics of these other things. But if anyone has ethical questions, then fire away.
Dr. Kiehl, I think we're at the end of our time, and I hope we can continue this conversation. I've been fascinated by why many of our, I don't know, cultural heroes in quotation marks are psychopaths, and why we just enjoy them so much. So having the science applied to this group has been really, really useful. I still don't know why we're so fascinated by them. But at least we know them better now for this talk. So thank you. And
thank you.
And if I could just take a minute to mention the next speaker in the series, it's Dr. Elizabeth Lawrence, who is going to try to take an ethical perspective on wellness. Wellness is one of those words like professionalism and that sort of thing, which we now use a lot. And she's going to try to assess whether there are imperatives to wellness, especially at the organizational level. So a very different talk, but thank you, Dr. Kiehl. This has been really fantastic. And I hope that we'll continue the conversation in one way or another over time. So thanks.
Well, thank you, everyone. I appreciate y'all. Well, you're probably watching